Good evening. Welcome to the EUROGEN webinar series. So just before we get started with this evening's webinar, I would just like to take a couple of minutes to explain a little bit about what an ERN is and does. So EUROGEN is one of 24 European reference networks covering different medical fields created and funded by the European Commission in 2017. And EUROGEN specialises in highly specialised urorectogenital diseases and complex conditions. And at the moment, we're a network of 52 healthcare providers in 20 member states. So what do we do? Well, the aim is to deliver quicker specialist evaluation and more equitable access to high quality diagnosis, treatment and care for patients with rare urogenital diseases and complex conditions who all need highly specialised surgery. And it's really conditions where the expertise is rare. So some of our activities, well, one, and you will have seen the slides at the beginning of the meeting, we provide virtual free consultations cross-border using a secure IT platform specially developed for the ERNs by the European Commission. So we can provide cross-border MDTs where experts can give any healthcare provider in any member state advice if you have a particularly tricky or complex case. We also collaborate on education and training activities like this webinar, and we also have other training activities. We're also developing a patient registry, and this is being rolled out now across all our healthcare providers. So the aim is in the future, in 25 years, we'll be able to collect long-term follow-up of the patients who have this highly specialised surgery. So the title of this evening's webinar is it's about cystinuria, and the webinar will focus on the prevention of recurrences of cystine stones in children. And it's a great honour to have Anna Bujons with us this evening, and she is head of Pediatric Urology Division in the Fundació Puigvert, Barcelona. And she's a member of the Educational Committee of the ESPU, and she's also a board member of the EAU's EWPU. So thank you very much, Anna, for sharing your expertise here with us this evening, and I'll give the floor over to you. Thank you very much.
Good afternoon, ladies and gentlemen. It is a great pleasure to present this session of Cystinuria. Thank you very much to the EUROGEN for this kind invitation. I have no conflict of interest, given that cystinuria is a metabolic disease without definitive treatment mutation in the STLA C33A1 or C33789 genes. Recurrence of lithiasis in these patients are very frequent. Recurrence of lithiasis in that patients are very frequent, occurring in more than 60% of cases are requiring an average of 0.60 surgeries per year. And in the long term, the decreased kidney function, which is already affected in 70% of these patients. The small size of the kidneys highlight the need for minimally invasive procedures to achieve a high rate of success without an increase in complications. Furthermore, this crucial high success rate should be achieved in a light setting to avoid exposing the child to repeat anesthesia. The aims are complete elimination of stones, prevention of recurrence, preservation of renal function, and minimize morbidity and hospitalization. Cystinuria is the most common genetic cause of nephrolithiasis in children, and cystinuria represents from 6 to 8% of pediatric stone disease, and overall prevalence of cystinuria is 1 per 7,000 with high heterogeneographic variation, and more than 60% of cystinouric patients develop cystine stones in their lifetime, and 70% of both kidneys. Among the patients for recurrent stones with the need for repeat interventions, and the management of cystinuria is different from stone disease in these typically young patients owing to the frequency of a stone recurrence and necessity for multiple interventions to prevent stone-related complications, particularly chronic renal failure. Cystinuria management requires a multimodal approach from diagnosis to treatment and the prevention of stone episodes. Our understanding and experience of managing cystinuria has increased in the past decade owing to research into the disease, advancing in genetic testing, and general improvement in stone management in children. On the other hand, cystinuria is an autosomal recessive hereditary disorder characterized by a defective absorption of cystine and the basic amino acids in the renal proximal tubule and in the epithelial cells of the gastrointestinal tract. But what is the molecular base? The cystine transporter is an heterodimer comprised of two subunits joined by a disulfide bridge. The interaction of the heavy subunit RBAT and the light subunit B0 AT is essential for the functional expression of the whole system. Two genes responsible for cystinuria have been identified: SLC3A1, which encodes the heavy subunit RBAT, and SLC7A9, 19q12, that encodes the light subunit B0 blue AT. High cystine excretion leads to crystal precipitation in the distal tubule and formation of cystine stones due to its low solubility at normal urine pH. As you know, three phenotypes of cystinuria have traditionally been described on the basis of the urine excretion of cystine in the obligate heterozygous parents. Typically, type A, the most common, 60% of the cases, heterozygotes with normal urine cystine excretion, and homozygote have altered urinary and intestinal cystine transport. Type B, heterozygotes have altered urinary excretion of cystine and the basic AA, and homozygotes show normal intestinal absorption and increased excretion of the basic amino acids of urine. And type AB, no intestinal alteration, and both homozygous and heterozygous urinary excretion intermediate between 1 and 2. More recently, a genotype classification of cystinuria was introduced, important although they are conflicting. Neither the genotypic nor the previous phenotypic classification appear to be relevant with respect to the clinical course in patients with cystinuria. No differences in the age of onset, number of stone emissions, of total stone events between those with type AA or BB was detected. AA or BB will denote two mutated alleles in the two genes anteriorly described respectively. For example, A0 and B0 denote the identification of only one mutated allele. Even by extensive genotyping, carriers of genotype A0 usually have normal cystine excretion, whereas carriers of genotype B0 have often elevated cystine excretion, however, very rarely develop stones. But what is the role of genetic analysis in routine clinical practice in our pediatric patients? There is a clinical practice recommendation from many experts from the Reference Network for Rare Kidney Disease, ERKNet, and EUROGEN members. They conclude that genetic analysis is not mandatory for diagnostic practice, useful in the context of atypical presentation. In our practice, it is very useful for family genetic counseling. For example, we had recently an index case of a 5-year-old who had 4 more brothers. One of them was his twin, so 3 of them were affected. No stones, but 2 of the 3 with positive crystalluria with a high risk of lithiasis, so they follow it up is very important. For example, in cases with prenatal diagnosis of hyperechogenic colon, genetic testing can be recommended for the early diagnosis of cystinuria, as urinary amino acid excretion is difficult to interpret in the first years of life because of tubular immaturity. Detection of hyperechoic colon as routine ultrasound before 36 weeks of gestation may suggest a diagnosis of cystinuria with a high positive predictive value, 89%. The proposed explanation of this observation is that cystinuric fetus have high cystine observation in that cystinuric fetus have high cystine concentration in the amniotic fluid. As the fetus constantly swallows, transport system is exclusively expressed in the small intestine. Ingesting amniotic fluid with high cystine content would result in overload on the intestinal receptive capacity, causing high cystine concentration and precipitation in the colon. In any case, confirmation of the diagnosis should be made after the delivery. The first renal stone detection can occur very early and exceptionally at birth, suggesting the possibly prenatal formation of stones. Due to the recurrent nature of cystine stones, complete stone clearance should be achieved whenever possible with a patient-specific surgical approach. These mostly minimal invasive procedures carry the risk of impairment of renal function. According to the European Association of Urology guidelines, the first-line treatment for renal or proximally uteral stones less than 2 centimeters in children is extracorporeal shockwave lithotripsy. However, cystine lithiasis is usually resistant to treatment with SWL, stone-free rate less than 60%. In this context, flexible ureteroscopy could be playing a fundamental role in patients with stones smaller than 2 centimeters, offering not only a minimally invasive approach with fewer kidney complications, but also a better stone-free rate thanks to the incorporation of laser technology. Although cystine stones are generally considered harder and more resistant to SWL, these cases, reasonable outcomes has been published by well-trained urologists in children. A French study compared SWL in two groups, less than 2 years old or more than 2. The stone-free rate in less than 2 years old were 83% against 8% in older, and then conclude it is a good option for patients less than 2 years old, not older. In our experience, we have good outcomes with the SWL in recent recurrence of cystine stones. On the other hand, as Slakovic reported, a stone-free rate less than 50% after 4 sessions in patients with cystine nephrolithiasis, and Dogan excludes such patients from their pediatric SWS efficacy prediction nomogram because the success rates were only 37% of success. What about the flexible ureteroscopy? We underwent a prospective study to know if the cystinuria can decrease the effectiveness of flexible ureteroscopy in children. We had a stone-free rate of 59%, but patients had more than 3 surgeries previously. The anatomy of 73% of the interventions increased the difficulty of flexible ureteroscopy and decreased stone-free rates because distorted renal anatomy was present, sclerosis of the pelvis of indubulum, abnormal calyceal dilations of excluded calyx. Intraoperative complications occur in 80% of the procedures. Cystinuric patients are a challenge for pediatric urologists, decreasing the effectiveness of flexible ureteroscopy. However, it could be better treatment than this SWS and with fewer complications than PCNL in the pediatric population with this disease. In 2017, EURIC published the series of 14 flexible ureteroscopy in children with cystinuria with a stone-free rate of 100%, but they did not clearly define the parameters regarding a stone-free rate, and they did not describe complex anatomy within their interventions. When PCNL is undertaken, newer miniaturized techniques may be beneficial in reducing trauma to the renal parenchyma in recurrent stone formers. If ureteral stent placement is considered at the end of an urological procedure, ureteroscopy of PCNL, the time of underwelling should be minimized due to the risk of incrustation. We performed a study with high-power laser on mini-PERK. 70% of them were from cystine. The overall stone-free rate was 80%. The literature published a stone-free rate around 70%. We conclude the high-power laser was very helpful in this kind of stones. So, first, it is mandatory to complete stone clearance as much as possible to prevent recurrence with the techniques described anteriorly, but medical treatment is crucial to reduce cystine saturation in urine and increase its solubility. Conservative treatment is based upon a stepwise strategy using hydration to maintain cystine concentration below 250 milligrams per liter, reduce sodium and methionine diet, and alkalinization with potassium citrate to reach urine pH 7.5 to 8, as basic measures with the addition of trial derivatives in refractory cases. Treatment will be based on dietary measures, high water intake, urinary alkalization, and pharmacological treatment. The mechanisms involved in cystine kidney stone formation are related to the high concentration of cystine and its low solubility at normal urinary pH. Cystine solubility is below 250 milligrams per liter and pH low 6 and reach 500 milligrams per liter at pH more than 7.5. Fluid intake should guarantee a urine output large enough to maintain a cystine concentration below 250 milligrams per liter during 24 hours. In children, over 2 liters of urine output is required for excretion of 1 gram of cystine per day. Patients should be strongly advised to consume fluids before bedtime and upon awakening. You use urinary alkalinization to increase the pH. Use polycitra in children in syrup. It prevents cystine precipitation and stone formation. Control other predisposition factors, calcium, phosphorus, augmentation of probability of formation of calcium phosphate crystals. Potassium citrate should be given in 3 to 4 single doses, including large bedtime dose, or diluted in large volumes of water. The diagnosis of cystinuria can be confirmed by the measurement of elevated levels of cystine and the basic amino acids, ornithine, lysine, arginine, in 24 hours urine specimens. And for small children who cannot yet control their voiding the first or second morning urines, are the more suitable and results should be reported relative to the creatinine level to compensate for urine concentration. Sorry. Thirdly, Reduced methionine intake lowers cystine production. Restriction of animal protein intake is recommended in adults, but the protein restriction is not advisable in children for concern about growth. When the conservative measures described above are insufficient after a 3-month trial period, a thiol-based drug regimen is usually the next step in active cystine stone formers. As a general guideline, most patients with a 24-hour urinary cystine expression of 500 milligrams or more are likely to need a thiol medication in addition to hydration and alkalinization therapy. However, cystine binding agents carry severe side effects. There are other treatments such as captopril. It also has a thiol base and has the ability to form highly soluble mixed disulfide captopril and cystine. The reasonable option is a cystinuria patient with hypertension. Effectiveness is stone formation with conflict results, safe and few side effects. And butylamine could be another option, is it was available in Japan or Korea. Theoretically, it's more effective than thioprine and better tolerated at low doses are needed for the same effectiveness. And low toxicity and far 3 studies in the US, currently in cystinuria. New drugs are developing. L-cysteine diamides have really proposed as L-cysteine crystallization. There are inhibitors for cystinuria, but their routine clinical use has not yet been validated. Alpha-lipoic acid inhibits cystine stone formation in mice, and its use has to be further evaluated in humans. And tolvaptan decreases urinary oversaturation. But how do you follow up these patients to prevent recurrence? With the imaging techniques, role of crystalluria. What is the role of crystalluria? Urine cystine monitoring of urinary parameters, supersaturation test. What is the role of self-monitoring? We follow up the pediatric patients with ultrasound every 3 and 6 months, and we monitor the urinary cystine concentration in patients with cystine binding drugs. And what is the role of crystalluria? Crystalluria is a useful tool in the management of patients, but assessing crystalluria requires a standardized methodology that is not available in some centers. What is the real role of crystalluria? That is important. Can be predict stone formation. The crystalluria useful tool management and could be comparable to the ultrasound. A positive association has been shown between stone activity and crystalluria in urine. The optimal timing of urine samples for assessing a crystalluria is debated, with some authors showing positive association of stone activity with samples obtained during clinical visit with early morning urine samples. In principle, monitoring crystalluria may allow tailoring of radiological investigations, but prospective studies are needed. Assessing urine supersaturation may also be helpful to evaluate the efficacy of cystine binding thiol drugs with reducing supersaturation. Measuring supersaturation may reduce the variability in cystine excretion that is related to differences in urine cystine solubility. A proprietary assay has been developed to determine cystine capacity by measuring the solubility of cystinite to urine samples. And finally, the self-monitoring is very useful. It allows to compliance to treatment, including alkalinizing agents, has been associated with fewer urological interventions. Recently, smartphones applications has been developed to remind patients to drink and to monitor to water intake. Preventing stone formation is an important focus for the clinical undertaking, especially to the long-term cystinuria management and care. The urologists aim to minimize the frequency of renal colic episodes, the need for urological intervention, and the adverse sequel to recurrent stone formation. take home message. What is our conclusions? Patients with cystinuria require frequent follow-up and a multidisciplinary approach to diagnosis, prevention, and management. Patients have reported success in prevention of stone episodes by maintaining dietary changes using a tailored review from a specialist dietitian. For patients who do not respond to conservative lifestyle measures, medical therapy to alkalinize urine and tail binding drugs can help. A preemptive approach to the surgical management of cystine stones is recommended by treating smaller stones with minimally invasive techniques before they enlarge to a size that makes management difficult. However, a multimodal approach can be required for larger complex stones. Currently, cystinuria research is focused on methods of monitoring disease activity, novel drug therapies, and genotype-phenotype studies. And finally, the future of research is a collaboration at a national and international level, facilitated by groups such as ERN, EUROGEN, and ERKNet. Thank you for your attention.
Okay, that's the end of the presentation. So Anna, if you can put your camera on, that would be great. In the meantime, if anyone now has questions, please do type them in. I'm just going to stop sharing the video screen. So excellent. So just while people are doing that, just a reminder that today's session has been recorded. I'll send out the links tomorrow directly to the recorded version, and that will be the link for both GoToWebinar and for our YouTube channel. Also a reminder to attendees that you'll get a survey straight after this session. If you can complete that, that's brilliant. We're about to start doing the analysis of the past batch of sessions, so ready for the summer. So if, your feedback will be taken into account very soon. And please check out our website for future sessions as well. We've updated a few earlier on, and other registrations are open for future sessions. So just waiting for some questions to come through. Nothing at the moment. So let's give people a few minutes to do so.
Good afternoon to everybody. Thank you for your attention.
I don't know if there's anything you want to add, Anna, at all to anything, or not, no worries, but
no.
So yeah, if people want to type in.
If you have some questions, or if you want to send to an email, you can do that. Everybody have my presentations of. You feel free, no?
Yeah. So if anybody does have questions after this, you'll definitely have my email address through the communications for this session. So you can send them on to me, and I will pass them on to. Also, anybody watching this in the future on YouTube, you can either send again to me, or you can also comment to the YouTube comments, and our business manager Jen will monitors those. So we also pick questions up from there. So anybody who's watching this and missed it, don't worry, you can still put your question forward. So does anyone have any questions? I'm going to give everyone another 30 seconds or so to do this. So just while we're waiting, I'll give a few more seconds. I'll just say also, this webinar is not accredited. So we haven't got any accredited webinars before our summer break, which is from July the 19th, is the last one prior to our summer break. But all the rest of the webinars, the 12 more from September to December, they all will be accredited now. So we have got managed to sort that out for those, and we'll hopefully carry that on into 2024. But on the website now, we've also updated our table of a list of webinars to show whether they are accredited or not. So if you look on our website, you'll be able to see whether a session is accredited or not. Okay, we don't have any questions. So, oh, here we go. So, We've got one, so it's good. Okay, I just want to, okay, I think it's incomplete question possibly from Julia. I don't know if you want to just add to that, Julia. I think you're going to type something else. So I'll just give it a second while, right, here we go, yes, okay. So I'll read this out. It says, so Julia says, I couldn't be present at the whole presentation, but I want to ask if genetic is mandatory to start therapy with thioprenine. Does that make sense, Anna?
Is it that the question is about the thioprenine?
Yes.
Yes, but when we'll start about the thioprenine?
So it says, is it mandatory? So if genetic, is it mandatory to start therapy with thioprenine?
No, it's not mandatory. We'll start the thioprenine when it's more than 100 milligrams in urine. It's the cystinuria. It's more than the methionine, more than with 500. Is in the slide. You can see that is when you start with thioprenine. It's not mandatory. This treatment is when the level is more than 500. But when you start the treatment without canalization, the first is what diet. Then when the second is alkalinization with citrate and the pH more than 7.5, and the third, when the level is more than 500 in the urine, is when you start with thioprenine.
Okay. Yeah, Julia says thank you for that. So I think that's all clear. Okay, anybody else? Okay, I'll give another 15 seconds and then as I say, please don't hesitate to send anything afterwards if you think of anything, or anybody say watching this back, please don't hesitate to get in contact with me. We will do our best to get you answers to questions going forward. Okay, I think that's all we've got. So so thank you to everyone who attended, as usual. Please remind you, we'll get a survey afterwards. Please do fill it in if you can, if you have time. Most of all, thank you to Anne for taking the time to do the presentation. And yeah, it's been very good having you here. So thank you very much. So I hope, I said, everyone, you can find future sessions, details of those on the website. Please check that out. Otherwise, I wish everybody a good evening and hopefully see everyone again soon.
Okay, thank you all the attendees.
Thank you, Anna. Take care, everybody. Good night.
Bye. Bye.